Welcome to ePhysicians Office, Inc. I am Dr. Victor Levy, CEO and founder of ePhysicians Office, Inc., referred to as ePhysicians Office for the purposes of this discussion. Permit me to tell you a little bit about myself and the company. I've been a physician in clinical practice for 35 years and have developed information systems for the past 20 years. My medical degree is from New York, and my internal medicine and gastroenterology training took place at the Albert Einstein College of Medicine. I'm presently an attending gastroenterologist at Bassett Healthcare System in central New York, a teaching campus and affiliate of Columbia Presbyterian Medical Center and Medical School. We have built, patented, presented, and published numerous actionable applications in clinical IT over the past 15 years. Our current IT team and clinical liaison management teams have been in place for over a decade. There has been a good deal of discussion and initiative in incorporating IT into healthcare to improve service outcome and cost. The approaches to data have largely been related to financial and operational applications. Clinical applications have been overlooked, or when attempted, are not truly reflective of or offer actionable insight into the actual clinical environment. ePhysicians Office is a game changer with regard to how clinical data analytics is conceived from a variety of perspectives with the use of embedded AI machine learning technology. We will show you how and why. Data and technology can assist significantly. However, data needs to be structured and analyzed correctly. Healthcare-specific IT needs to be built, not healthcare-adopted IT. IT built from and for clinical decision methodology and fueled by appropriately cleansed and assembled data. The J.P. Morgan statement is from the annual conference of CEOs, CFOs, and COOs of the largest hospital systems in the nation. 2021 conference main topics included digital health, artificial intelligence, and deep learning. As of 2021, only a minority of health systems have a robust digital health strategy, but it's coming. What's needed is a nimble, customizable e-infrastructure, not simply claims-based algorithms, which are all too common, leading to either-or solutions to a pain point. Instead, a stratified set of potential solutions, a probability ranking, if you will, that emulates a patient-provider interaction, such as differential diagnosis, choice of medications, disposition, and triage. In other words, actionable solutions from the ground up. COVID is uniquely suited for data analytics to assist every element of the pandemic. The problem is that it was in place in only a minority of hospitals. Even within the relatively small percentage of healthcare systems with a bona fide IT strategy and budget, senior management was occupied with putting out fires, personnel issues, increasing ICU capacity, etc., rather than interest in data capture and initializing new IT tools. It needs to already be in place for when and if. To further the point just made, this graphic was displayed by Jeff Rakes in 2000 at a eHealthcare World Conference and is as relevant today, if not more so than then. Data points are best selected by a standing committee of in-house senior management, providers, in-house EMR representatives, and IT personnel, working side by side with ePhysicians Office physician specialists. 1, to build a customized solution for any identified pain point within the facility. 2, expeditiously beta test it. And 3, effectively introduce it to all stakeholders. There is a downside to delay in the use of predictive analytics and machine learning. First of all components of an illness should be analyzed: outpatient versus inpatient, or acuity, the type and frequency of provider encounters, be they primary care providers or specialists, the need for procedures and tests, and treatment options. Multivariable, homegrown algorithms are needed, and this is exactly what we do. CMS incentives for value-based care is clear, and in regard to this point, I am preaching to the choir. This AI machine learning approach is, quote, to not only answer the questions we cannot answer today, but to answer the questions we cannot envision today, end quote, as stated by AHRQ in Washington, D.C., where I spoke several years ago. System competitors, using advanced analytics, will cherry pick the most predictable components and make inroads into service, outcome, and cost, resulting in 1, insurers taking notice, offering preferred contracts, and 2, opportunities for marketing and consumers taking notice, particularly educated consumers. Regional needs need to be met with regional data and solved locally. ePhysicians Office offers its experience obtained in a spectrum of clinical settings and different regions: academic versus community-based, urban versus rural, voluntary, for-profit, and VA facilities, private practice versus group practice, emergency department versus clinic. Regions include the Northeast, the Southeast, and the Midwest. What works for one may not work in another. Think of the process of introduction as a circle with 4 points, each one leading to the next in a never-ending cycle of process improvement, with all stakeholders motivated and involved, and facilitated by ePhysicians Office personnel and IT. The points in the circle are: 1, build a data analytics model with return on investment included, together with the facility team, to ensure quality and beta testing. 2, develop directive strategies with physician leaders. 3, inform all stakeholders, providers, of plan for implementation. 4, follow workflows for quality of care, any disruption, and return on investment. Reiteration then follows. We can modify the model and then return to point 1. The ability to begin each project in identical fashion, regardless of the topic, with EHR-derived clinical data fueling a generic template, engenders familiarity and efficiency by the facility team. The database is transformed into a decision algorithm by the proprietary Bayesian-based software with real-time depiction of statistical parameters, which is desired by physicians as part of any beta test of the analytics tool. Automated analysis of new data sets or patients to be evaluated with resultant ranking of decision alternatives can then take place. These newly completed data sets, in turn, with their eventual diagnosis, are incorporated into the database as well, in real time, generating bona fide machine learning artificial intelligence. Data may be aggregated from multiple sites within the IDN, resulting in a system-wide algorithm within an e-infrastructure. Here are the features of ePhysicians Office. As mentioned earlier, this quote was stated by a thought leader in innovation at an AHRQ conference in Washington in 2007. I had presented the clinical analytics concept to AHRQ in 2007 when the fledgling field was referred to as bioinformatics and clearly was not as yet ready for prime time. Processing of thousands of data sets simultaneously and processing from multiple sites with aggregation of the data. The providers can orchestrate its deployment to ensure seamless integration. Artificial intelligence capability via ongoing addition of data sets. On-site depiction of validity and reliability in real time. The uniqueness of this functionality will be evident. Incorporated within clinical pathways and processes with the direction of your team with our assistance. And IRB-approved studies have already been completed, published, and presented, including workup of chest pain in the emergency department, clinic non-attendance or no-shows, Barrett's esophagus, the management of C. difficile infection in outpatients, and currently under study, management of incidental strokes. Let's expound on some of these features. Clinical variables are incorporated into the predictive tool, and multivariate outcomes, more than two, are easily accommodated and potential outcomes ranked. Simultaneously, real-time statistical monitoring detects changes in the relationship between a single variable and an individual outcome when new data sets are added, perhaps indicating a variation in a recognized disease or a new syndrome, such as COVID with thrombotic complications. To facilitate beta testing, we utilize automated, replicative processes and reiteration with ease of use to maximize statistical validation. Physician, senior management, and IT in-house collaboration select pain points in clinical processes to be addressed. As stated earlier, the ideas come from within. The architecture is generic, therefore applications are unlimited. These applications, again, are selected by the facility. We have expertise in this space for almost 20 years. Educational curricula for all levels of providers are available upon request. The original patent was issued in July of 2006, and we have superseded the initial rendition. Our website describes the concept behind the functionality and has details of our approach to chest pain in the emergency department, which we will discuss later on in this presentation, and COVID applications, which we will mention as well. Presentations and publications have included American College of Gastroenterology and American Gastroenterology Association annual meetings, the American Journal of Medicine, the Institute of Electrical and Electronics Engineers, otherwise known as IEEE, the Agency for Healthcare Research and Quality in Washington, D.C., and the National Emergency Management Summit. Restricted access to website functionality to selected individuals has maintained security of data, and there is continuous security monitoring of online access 24/7. This is not business as usual with regard to IT. These custom algorithms deal with direct bedside clinical decision analysis as well as administrative and triage issues across the spectrum of healthcare delivery, and as mentioned, created for any facility's specific needs. Applications completed include clinic non-attendance or patients likely to no-show for a visit, chest pain in an emergency department, whether to admit the patient as an observation patient, whether to regular admit the patient, or whether to discharge to clinic follow-up. Clostridium difficile infection and evaluation of clinic patients to reduce the risk of subsequent hospitalization. what is referred to as an IDN determinant study, predicting the acuity level and hence cumulative expenditures of cardiac patients for the following year based on their medication list. Therefore, can estimate the number of primary care provider visits, number of cardiology visits, the need for admission, number of admissions, the need for cardiac cath or subsequent surgery. The physicians at ePhysicians Office work side by side with in-house providers. Curricula introduce staff to the true value added of clinical data analytics, improving service, outcome, and cost. Evidence-based measures of statistical significance are built into each completed tool, and this is a key to acceptance by physicians vis-a-vis validity and reliability. A unique feature of ePhysicians Office's functionality is online repetitive automated extraction of a requisite number of data sets from the master database to create another version of the same decision-making algorithm, populated by a fresh set of automated mathematical computations based on those newly extracted data sets. These additional reiterations may be saved. The thresholds and statistical measures of all reiterations may be compared online, that is, apples to apples, to verify the internal validity and reliability of the algorithm. There are numerous levels of service offered by ePhysicians Office. The premier product, which I described, is a completed decision-aiding probabilistic algorithm built and placed online, and facilitation of its inclusion into existing workflows for use by providers with our ongoing involvement. Other services include simply performing an independent analysis of data using our analytics software and offer consultation only. Educational in-service on clinical data analytics can be conducted for all providers and students. Pricing is related to level of interaction, degree and duration of access to on-site functionality, and the number of applications. A few words on getting physicians on board. We know from experience the need to enlist some rock stars from the medical staff, true thought innovators from local leadership. A big data non-medical consultant has stated, quote, "If you're going to succeed in big data, you need a thick skin because you'll get a lot of pushback. You need to define clear roles and responsibility if you're going to do it," end quote. But it's worth it. The advantages and value added are bona fide and measurable. So, practically speaking, don't create any more barriers to access than necessary. Small practices often require additional technical support for implementation, and make sure it works all the time. To expound on the comment on the last slide, if it doesn't, quote unquote, work all the time, a provider simply seeks the path of least resistance. We realize that there is no time to learn technology on the fly when it is not intuitive, if the provider is in the midst of a clinical shift. This slide summarizes what is necessary for physician cultural transformation. This states what is necessary to making providers data literate and bridge what we refer to as the digital divide. This is a problem for which we developed an application enacted some 15 years ago and was launched in a voluntary hospital system in Florida. Chest pain presenting to an emergency department accounts for almost 2 million hospital admissions per year in the United States and amounts to $10 billion per year in expenditures. About 70% of admissions are unnecessary hospitalizations. Between 2% and 8% of patients with myocardial infarction are discharged from the emergency department. The evaluation and management of chest pain presenting to the emergency department is truly a case study in service, outcome, and cost. When confronted with need for a value-added solution, clinical data analytics has been proven to step up to the plate. A probabilistic predictive online tool was created based on bedside collected data, variables, which were placed into a matrix, along with their confirmed diagnoses, followed by automated mathematical calculations between each variable and each outcome. The result was a clinical analytics algorithm that could be used as a decision aid to guide management of patients without a clear-cut acute coronary syndrome or other significant etiology for their presentation. And it was effective. A clear threshold can be set, which was 100% effective in detecting ischemic patients and 83% effective for non-ischemic. The computed hospitalization rate, 32%, approached optimal chest pain triage, 70% discharged. The tool effectively scored non-ischemic patients with GI and psychiatric diagnoses, the two most common categories. The results of the algorithm were shared with physicians and management, with resultant substantial decrease in unnecessary admissions. The results were presented at an ACG annual meeting. Here are the value-added financials for the chest pain algorithm. Projected cost savings over a year for a moderately sized ED, seeing 10,000 patients per year with chest pain as a result of AI-assisted diagnosis and triage of patients. These savings are reflective of decreased observation status and regular inpatient admissions, as well as averted inpatient denials of reimbursement by insurance carriers. Reimbursement estimates were obtained several years ago and may slightly differ from those stated. Operating expenses, which represent cost, are likely even higher than those stated due to labor cost increases. The additional ED conventionally reimbursable charges reflect the additional time spent by the patient in the ED and a radiographic or nuclear medicine test to rule out cardiac ischemia in identified patients, which is an independent reimbursable charge when performed as part of an ED stay, in addition to the standard ED charges. A conservative estimate for total savings is in the $2 to $2.5 million range per year for an average size hospital ED that sees about 30 patients per day with chest pain. Details of all cost assumptions and savings based on the IT-aided triage decision-making algorithm are available upon request. Let's look at another completed and published application. Here we improved the predictability of patients not showing for scheduled clinic visits, simply by automated analysis of data extracted from the EHR at a VA hospital in New York. The no-shows rate was about 1 in 7. With automated analysis of the data sets from the available 4,774 in total, a threshold was IT generated, which maximized sensitivity and specificity. Multiple runs of data analysis were performed in a reiterative fashion of 668 patients, and the same threshold was generated again and again, representing about 40% of the total number, implying validity and reliability of the tool. The result? we increase the predictability of a patient not showing by a factor of 4. So, how does this translate to the real world? A clinic is scheduled for, let's say, 20 patients. Given the 40% of patients that meet or exceed the threshold, that computes to 8 patients that are at a computed probability of not showing by the algorithm. These 8 patients can be phoned rather than all 20, which is labor intensive, and on average, 2 of the 3 potential no-show patients will be in this group. Thus, the tool directs clinic staff attention to the patients likely not to show, which limits overall clerical work. Double booking is possible for certain slots, or a schedule with a greater number of patients that meet threshold for no-shows may allow for less staffing. The results were published in IEEE, the premier online peer-reviewed engineering journal, and presented at Stony Brook University Center of Excellence for Wireless and Information Technology annual conference in 2013. This application repurposed the same data sets from the VA data warehouse utilized for the last study. Here, however, 3 data dumps, the one from the prior facility plus 2 additional facilities within the VA system, were aggregated. This is an excellent example of reworking previously used data and creating a new dependent variable or outcome, in this case, patients at risk for serious psychiatric illness. A total of 7,874 data sets were utilized. The assembly and analysis is identical to the prior study. An identical number of data sets with each outcome is used to build the algorithm, referred to as ratio analysis, which is then tested against a separate compilation of data sets to establish a threshold. Multiple runs are performed to determine reliability and validity. In this case, the predictability of a patient having serious psychiatric illness, that is 3 or more psychiatric ICD codes in the problem list, almost tripled. So again, we extrapolate the results to a real-world scenario. In a clinic of 20 patients, 3 to 4 patients will be computed to be at risk for serious psychiatric illness, 3 or greater psychiatric ICD codes in their problem list. These patients can be phoned, and a basic questionnaire of perhaps 3 questions posed, and the likelihood of the need for intervention ascertained. At least one of these 3 to 4 patients that are phoned may be at risk. Once again, a set of selected EHR-derived variables can be extracted to build a customized algorithm to address any clinical pain point suggested by management, with measures of statistical validity and reliability displayed for stakeholders. In 2019, an algorithm was created at Bassett Health Systems to address their pain point of clinic patients with C. difficile, who often experience clinical deterioration and eventually required hospitalization. Aggregation, assembly, and analysis of EHR extracted data from multiple facilities resulted in the finding that clinic patients on acid-blocking medications, such as Pepcid or Prilosec, were more likely to be hospitalized for C. diff than those not on those medications. Reevaluation of the benefit versus risk of continuing these medications was a demonstrable example of improvement in service, outcome, and cost. This clinical finding, incidentally, was never previously reported. As mentioned before, COVID represented an ideal scenario from multiple points of view to use the power of AI to direct strategic clinical decision-making from bedside to public health policy. The Silent Stroke Intervention Project may be a landmark study that will ultimately answer the continuing question of how to manage the patient with an incidental stroke by CT or MRI. Once again, EHR-derived data will create the algorithm that will direct optimal approaches to workup and treatment of these patients to improve long-term service, outcome, and cost. The future? I expect that most of clinical decision-making will eventually have an integrated AI component, thereby making a clinician a better clinician by creating a concerted approach to patients that displays both clinical excellence and fiscal stewardship. ePhysicians Office is prepared to meet these challenges.